Welcome to the 229th of the COVID calls. This is a daily discussion of the COVID-19 pandemic with a diverse collection of disaster experts. My name is Scott Gabriel Knowles. I'm a historian of disasters at the Korea Advanced Institute of Science and Technology. I'm coming to you live today from Daejeon, South Korea. Today is a discussion of COVID-19 and mental health in Turkey with Dr. Cengiz Kilic. Just a reminder, you can catch COVID Calls live every weekday at 5 p.m. Eastern Time on YouTube. Just go to the COVID Calls YouTube channel to watch. You can also watch COVID Calls on Facebook Live, Twitch, and Periscope. A programming note, today and probably on several days, probably on Fridays coming up, we'll move to Fridays being on Korea time, and I'll be sure to make announcements well ahead of time so that you can plan your schedule for watching COVID Calls. You can also hear COVID Calls anytime recorded as podcasts on Spotify, iTunes, Podbean, or anywhere you get podcasts. You can also keep up with COVID Calls via Twitter using the handle @US of Disaster or @COVID Calls. Please do help spread the word and send suggestions for future guests and future topics. Please feel free to suggest yourself as a future guest. As of today, February 26th, 2021, there are 2,506,344 deaths from COVID-19 globally. That's according to the Johns Hopkins University Coronavirus Resource Center. There are 28,358 deaths reported in Turkey as of today, and 1,581 deaths from COVID-19 reported in South Korea. As a way to bring some humanity to the numbers, I've been reading a life story or a story of advocacy for those impacted by the pandemic, and I'd like to continue that now. This is an obituary of Cemil Taşkıyoğlu, professor and specialist in internal medicine, born in Rize, Turkey in 1952 and died in Istanbul on April 1st, 2020. This appeared in The Lancet. Cemil Taşkıyoğlu retained such a store of medical knowledge that he developed a reputation for diagnosing rare diseases. He became so well known for this skill that doctors around the country transferred undiagnosed cases to the Istanbul Faculty of Medicine at Istanbul University, Turkey, where he worked, knowing he was likely to have more success. His colleagues compared him to the fictional television Dr. Gregory House from the series House. The comparison extended only to his abilities, though, and not to his personality. While the television character was acerbic, Taşkıyoğlu, a long-time professor in the university's Department of Internal Medicine, was very compassionate and helpful towards students, residents, and patients, said Sukru Palandus, who first met Taşkıyoğlu as a resident in the department. Palandus, who is now a professor in the Istanbul Faculty of Medicine and chair of the Division of Internal Medical Sciences, said Taşkıyoğlu would not only teach students medicine, but also give them life advice. Taşkıyoğlu graduated from Istanbul University's Istanbul Faculty of Medicine in 1977 before completing specialist training in internal medicine there in 1982. After a stint working in Şanlıurfa in southeastern Turkey, he returned to Istanbul University in 1989, settling in the Department of Internal Medicine. He was named an associate professor in 1993 and became a professor in 1998. He was considered so invaluable that even after he retired in 2019, the university rehired him as an adjunct professor. Palandus said that participating in his clinical rounds was more valuable and informative than reading hundreds of pages from textbooks. Although Taşkıyoğlu was known for his diagnostic skills, his students said that he was happiest when they arrived at a diagnosis before him. He was always eager to honor hard work and complex thinking, said Gülistan Bahat, a former student of Taşkıyoğlu's and now a professor in the Department of Internal Medicine's Division of Geriatrics at Istanbul University's Istanbul Medical School. Taşkıyoğlu made the first COVID-19 diagnosis in Turkey, and it's believed he contracted the virus from a patient. A new research hospital in Istanbul has been named after him. He is survived by his wife Didem and three sons, Onur, Irem, and Deniz. Okay, I'm going to turn to my conversation for today, and let me introduce my guest. Dr. Cengiz Kilic graduated from Istanbul University Medical School in 1984, did his residency training at Hacettepe University, and I'm going to ask him actually probably to correct my pronunciation on that. Dr. Kilic, am I saying that correctly, or can you correct me on that, how to say that?
Okay, I mean it's a problem with the Turkish C. It's Hacettepe.
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 Okay.
Hacettepe. Yeah.
Thank you for that. And just to continue introducing you to him, he's currently professor of psychiatry, working full time at the psychiatry department of Hacettepe University Medical School in Ankara. As a member of the academic staff, he takes part in education directed both to students and residents, in addition to clinical work. His main clinical and research interests are in the area of anxiety disorders, traumatic stress, psychiatric assessment, and epidemiology. And after the major earthquakes of 1999 in Turkey, he took part as research and clinical supervisor in an international project led by University of London Institute of Psychiatry, where he also completed his PhD. He was the principal investigator of the first nationally representative epidemiological survey, the Mental Health Profile of Turkey, and the co-PI of the World Mental Health Survey Turkey. He is also associate editor of two scientific journals, the Turkish Journal of Psychiatry and the Journal of Traumatic Stress. Dr. Kilic, thank you so much for your time today, joining me on COVID Calls.
I thank you, Scott. It's a pleasure being here. Can I just say one word about Dr. Cemil Taşçıoğlu? I mean, it was such a touching obituary, and what a nice way to start such a program, such a talk. And he was not my. I mean, I haven't met him, but I probably because I graduated medical school before he started working there. But I have heard so many nice things about him, and it was such a touching and such a sad moment when we heard that he died after struggling for several weeks, maybe some months even. I mean, it took so long, and yeah, I mean, and the hospital was named after him, but I think that was not enough. It's just a very small thing to do for him. Thank you for bringing this up.
Well, thank you for your reflection on that. And I wonder, I mean, it's a good place to start. I'm going to ask you also a little bit about the situation there today, but his death and that reporting must have sent a jolt through the practitioner and scientific community in Turkey, as has been the case in other countries where a prominent physician or scientist dies. It somehow brought some extra gravity to the situation. It sounds like that must have been somewhat similar there.
Well, I mean, I agree, and I mean, to an extent, I agree. I mean, it's in Turkey, it's the events. I mean, the life evolves so rapidly. I mean, so many things happen, and the agenda changes so quickly. I mean, I mean, some people jokingly compare Turkey to Sweden, for example. And I mean, in Sweden, people, I mean, nothing happens there for many days. Nothing interesting, nothing tragic. So in Turkey, I mean, you're right. The loss of Dr. Taşçıoğlu, I think, made people realize how serious it is. After his death, people in the medical community, they started, I mean, raising their voices. I mean, they became heard, and there were slogans that this "you are killing us." I mean, just that they were addressing the government, meaning you're not taking enough measures and so on. But I think after that, so many other doctors died. And a couple of months ago, I mean, 2 or 3 months ago, when around November and December, when the deaths had peaked, and we started hearing 2 or 3 doctors dying every week. I mean, so I mean, if you count all the health workers, there are scores of them. But I mean, medical doctors dying almost every day or every other day. That's I mean, sadly, that changes the agenda of people. It's not easy to keep people focused on the deaths of doctors, and even I mean it's sad to say this, but sometimes it causes a backlash. I mean, I was telling you about how divided this country is before we started our conversation, and sometimes people say, well, I mean, it's their job. Why are they? I mean, screaming. Why are they whining and so on?
I want to just maybe find out a little bit at the beginning here. Maybe you could tell us where you're located, where you're calling from, and what's the situation like there today. If I was to walk down the street where you are, would I see people in masks or not, social distance or not?
Okay. I mean, I work at Hacettepe University Medical School in Ankara. I mean, Ankara is the capital of Turkey, and I've been working here for I forgot how many years, more than 30 years now. And just, I mean, if you, I mean, for a couple of years, I was away from this university. Just after for a couple of years after the '99 earthquakes, I had a couple of years of a break and went to the earthquake area. I worked there for 2 years and I did my PhD at London University, and came back to my university. So in Ankara, I would say, I mean, if you walk on the streets, you'll see everyone in masks, because there is a simple reason. It's required by the law, unless I mean, unlike other countries like the US, I think in Britain, I mean, you are encouraged to put on masks, and we are legally, I mean, forced to wear masks. I mean, you can see people wearing them on their chins sometimes, and the most common way to wear it is just leave the nose out, and just I mean, in passing, I would like to say that, I mean, we're now starting a study to find out if claustrophobia has any effect on this, because claustrophobics do not like their noses covered. So, and but in Ankara, I mean, largely you would see people in masks, almost everyone. In closed spaces, you would see, and some I mean, social distancing is not adhered to. I mean, as well as it in masks. So I mean, when I go shopping,
Looks like we've frozen for a second. In most cases, that clears up rapidly, and Dr. Kilic will be right back with us. Just a reminder that you're listening to COVID Calls, and I'm talking with Dr. Cengiz Kilic today, getting the perspective on his mental health research in Turkey.
Okay, are we back?
Yeah, look, I lost you for a minute, just not long at all, and you were telling us about the scene on the street there, social distancing not being as much of a player, but that the law requires the masks, and some people are following that.
Yes, I mean, when I go to the local shop, I can, well, I mean, people wait in the line. Well, I mean, some people observe the rules, some people don't, but masks are in place. But I mean, Having said that, this is Ankara. This is the capital. This is the one of the cities with the highest education level. I mean, in general. But I hear from other people from other cities where people, I mean, they don't put on masks at all. So I think, I mean, in larger cities, people observe this rule, but not everywhere.
So I wonder if you could just sort of set the landscape for us a little bit. You know, health systems around the world are so different. And even within the United
Right.
States, even within countries, you often have multiple different types of systems. But could you give me just a kind of a brief explainer when people talk about the health system and the response to COVID in Turkey? What does that look like?
Okay. I mean, in Turkey, the first thing to know is that it's dominated by the state. I mean, I think about 80% of all healthcare is provided by the state, and the private hospitals and private doctors and so on. It's just a fraction. So, and our health system is adapted from the old British system in the 60s, 1960s, when we just set up the primary care and this stepped approach. And there were primary care units were built all over the country, and so that there are the GPs, general practitioners, are the first point of contact everywhere. And although we couldn't make it work like the British did, it's very much in place now. I mean, their name has changed. The GPs have become family physicians. Sorry, but they are in every neighborhood. You would find one or two general practitioners where as a first point of contact. For example, they are the ones who are administering the vaccines now, the COVID shots, and so they refer you to the I mean, hospitals or to the university hospitals. But I mean, from the British system, the university law and preventing them from doing so. Okay. So in fighting the COVID infection, and that was very helpful. I think. I mean, we can go into detail, but I mean, well, Turkey was not one of the best examples, but it did fairly well, I think, in fighting COVID. The government tried to play down or the numbers in the start, but apart from that, the handling of COVID in the countrywide was pretty good and evenly distributed, I would say. I mean, it was not like being good in Istanbul and bad in everywhere else. It's because of this GP system. I think it's pretty good.
So that means that for average citizen, they can walk into a clinic. Hospitals are locally situated, and the idea of distribution. You know, this is what we faced in the United States. Is we have huge pockets of the country in which healthcare is either not available or only lightly available, and then the idea is you surge care wherever you need it in the moment. That might work fine if you're not facing a 50-state pandemic, but when the whole country is under assault from a virus, that system doesn't work. Sounds like what you're describing is a much more even distribution of care across the country.
Yeah, definitely. I mean, I was saying it's modeled after the British system, and the general practitioner referring to the a local general practitioner who's responsible of, say, I mean, in Turkey it's about 3,000 to 4,000 people, a population. So it's the advantage of the system is that the GP knows almost everyone by name or recognizes their face, and and so and this is everywhere. I mean, everywhere we have GPs. It's not like the US. I mean, I if I mean, I don't want to divert the point of discussion, but it's sad to see how one of the richest countries on earth, the U.S., has done so bad in handling and COVID. I mean, the maximum death rates. It's a proof that the system is not working, and so I mean, Turkey is historically is modeling itself after US. So this is proof that it's wrong, right?
Any country that's modeled its health system after the United States will have to take a good hard look
Right.
after this. It's certainly Donald Trump played his role, but he didn't invent the health system in the United States.
Right.
I just to follow up, because your research is focused on mental health, and I have so many questions I want to ask you. I want to talk about the 1999 earthquake, but just to get a sense of the mental health resources in the country, does it follow that same pattern? Is it generally widely available that people can find mental health interventions in terms of therapy and also pharmaceuticals?
Well, I mean, I would say more or less. I mean, well, if you look at the distribution of mental health professionals, I mean, we are in short supply of clinical psychologists. But in terms of psychiatrists, I think there are. I mean, we're in a much better position, say, than 20 years ago. But the state, the Ministry of Health, is trying to. I mean, well, I mean, is trying to keep the distribution even by imposing compulsory service and things like that. So I would say, I mean, you would find a psychiatrist in smaller towns in distant parts of Turkey, but I mean, obviously, I mean, most of them are situated in Ankara, Istanbul, and Izmir, in larger cities. But still, you can find psychiatrists in many parts of the country. But apart from that, I mean, I would say compared to European countries or to the US, we have much less emphasis on psychotherapy. And in medical schools, I mean, the blame is on us, on me, and my colleagues and others, because in medical school we don't teach ways of healing without medications, without surgery or ECT or things like that. So, and another thing, I mean, well, treatments other than pharmacotherapy are harder to teach and take longer, actually. I mean, although they are more advantageous, they are cheaper. I mean, in the long run, they are more eco-friendly. You see, I mean, they don't have any side effects and things like that. But when you think about training someone in doing psychotherapy, it takes much longer, and administering it takes much longer. So we have a quite short supply of people who can provide psychotherapy. But I think not the state, but the Psychiatric Association or other associations are trying to fill the gap. I mean, there are lots of associations. Like, I mean, I know the sexual therapy. There is a sexual therapy association who trains psychiatrists after they become psychiatrists, after they specialize. They provide training so that, I mean, you can now find sexual therapists in distant parts of Turkey. I mean, which is shocking to me. I mean, I'm impressed when I hear someone from eastern parts of Turkey who has this experience and so can treat patients. So there are lots of and the Psychiatry Association of Turkey is, I think, very active and doing very good things and in training psychiatrists in different types of psychotherapies. So this is well, I mean, it's improving, but if you want to general picture, most of the psychiatrists just provide only pharmacotherapy, and only a minority of people are receiving psychotherapy. And people who can access psychotherapy are still mostly in larger cities.
Just a reminder, you're listening to COVID Calls, and I'm talking with Dr. Cengiz Kilic about the pandemic and focusing in on the experience in Turkey. And I want to turn the conversation now to really focus on the work you've been doing at this time. You've been extraordinarily busy, and congratulations on the work, and I want to hear about it in detail. You have mobilized a study pretty early on in assessing mental health impacts of the pandemic, both for people who've already been diagnosed with disorders, but also for people who haven't been diagnosed. Start wherever you'd like. I'd like to hear about all of it.
Well, I'm not. I mean, I have to confess, I'm not a fast acting person. I mean, we started to realize what's happening in March, mid-March, although we knew about the pandemic. I'm not sure if it was named, coined the pandemic at that time, but we knew it had arrived in Turkey, and I think we had the first death from COVID in March 20, something like. And suddenly, instantly, in a few days, if not some weeks, the studies started pouring in. I mean, everyone started doing COVID-related mental health studies. I mean, I sit as the associate editor of the Turkish Journal of Psychiatry. I know we received hundreds of studies done in a couple of days or weeks. And I'm sure you also read about them or know about them. And there are so many studies accepted by so many respected journals, Lancet and others, that proved to be fake or wrong in this havoc. So I resisted for some time in starting research instantly, but I focused on making some videos, training videos for the general public. And it took some weeks, but I think in late April or so, we made some 1-minute videos, because the attention span of Turkish people is not is not too long. And not just the Turkish people. I mean, if you are in a pandemic, if you are in a threatening situation, you don't have a long attention span. You need short messages. So we tried to distribute these 1-minute videos, and well, I mean, we couldn't. I'm heading a center of stress research center here. I mean, we have a Facebook page, we have Twitter, and so on, but only reaches a couple of hundred, maybe a couple of thousand people. So I posted them on the university webpage, but still, it did not reach millions. And then we started this research on the mental health patients. Our patients, the patients who we see it are our patients. And I wanted this to be, to have two aims for this. First, to see how the mental health patients and psychiatric patients are affected by the pandemic. I don't know if it's appropriate to say this, but I was trying to find a name for our study, and I jokingly referred to it as, "Is psychiatry really necessary?" The name of the of the study would be, because I thought we could see after when we end this study, we would see if our patients actually needed to come to us. Maybe we'll see that they stopped coming to psychiatry for several months, but they were doing okay. And so we would know that in a future pandemic or in a future alien invasion or something, we will need to worry about our psychiatric patients. Or another scenario would be to see if I mean which types of patients need care and which can wait for a year without any consultation. So at the second, my second aim was to involve psychiatric residents, people in training to be psychiatrists, in the research process. I mean, no other. I don't think any other. I mean, academician has done this, and I involved 12 psychiatric residents in this, and forced them or encouraged them to collect data, and I held, I mean, weekly meetings with them and to discuss what to do next, and review. And I think, I mean, well, I mean, at least some of them are now more motivated to do research. Maybe, I mean, I don't know, in the future, some of them may be researchers, but we are now about to complete data collection. So it's not a complete done study yet. We could reach 500, around 500 patients so far. So, I mean, we targeted about 1,000. Some of them, around 20%, I mean, did not want to participate. There were refusals, but we couldn't reach some because they were, I mean, they did not have appropriate phone numbers or so. And some were not just, I mean, eligible, meaning, I mean, they were had dementia, things like that. But I mean, I haven't analyzed the data yet, but I mean, I think the most important thing is that they have a very high rate of COVID positive. I mean, 10% of the people we called, they said they had a confirmed COVID positive. I mean, we did not check the hospital records if they're telling us the truth, but there is no reason to suspect. So
that's much higher than the background rate in the population. So that's pretty fascinating insight there.
Yes. Yeah. I mean, there are several conclusions to be made. I mean, I haven't analyzed the data yet, so but it could be very interesting. I mean, now I was talking to the head of the Psychiatric Association in Turkey the other day, and we talked about. I mean, they were trying to convince the Ministry of Health to include mental health patients in the priority list to be vaccinated. And now, I mean, in Turkey, the priority list of vaccination. I mean, the first group was the health workers, including myself. So we were all vaccinated in, say, about a month ago. And then the older people, the elderly, starting with the 75 plus, and then gradually going down. And I mean, but people who have serious chronic illnesses, they were vaccinated. They were started to be vaccinated, but mental health patients are not included. So our association is trying to convince. So our study results may be very helpful in convincing them. So it's my feeling. I haven't. I'm not sure about it, but it's my feeling that there are many mental health conditions that increase the chances of acquiring COVID. It's not just like severe mental health problems like schizophrenia. I mean, people who don't know. I mean, who have lost reality. I mean, there are people who have attention deficit, so they forget. I mean, they touch things and so there are or there are. I mean, there are other people. I mean, depression is so a common condition. I mean, depressed people would not care about acquiring COVID. They would also forget. They would be forgetful. So there are so many conditions, mental health conditions, that could increase the chances. And so it's important to, yeah.
That's such. Thank you for explaining it in that detail too. I had a fascinating conversation last week on COVID calls with a bioethicist at Johns Hopkins named Travis Reeder, and he
Mhm.
does research on areas that are in some ways overlapping or adjacent to some of the things you're interested in, and particularly looking at opioid addiction at this time, and
Mhm.
raising this quite difficult issue um, that people with pre-existing health conditions, obviously isolation has been the number one public health measure and lockdown, that because that's the one size that fits most, but it doesn't
Mhm.
work for everyone. And people who may need communities of care, and I think that might extend to what you're describing here,
Yep.
that isolation can exacerbate existing conditions and make things much, much worse for them. And so he was focusing on addiction, but that kind of logic must apply also to some of the kind of mental health conditions that you were just describing.
Definitely. I mean, I'm not an expert in substance use, but when I talk to friends who are experts, they say, well, I mean, we wouldn't like our patients to use drugs, but when they are confined to home, they cannot find the drugs, and they can suffer a serious abstinence, which may be dangerous.
Can be.
Plus, if they can't go out and find a joint or something, they may hit their wives. I mean, the violence at home increases. So there are very serious consequences. I mean, we have lots of. I mean, in the last couple of months, we had several psychiatrists committing suicide, and we don't know for certain if this is connected to COVID. I mean, post-COVID effects,
Mm.
or to depression. But I think I mean, confinement, isolation has a role, at least some role. I mean, in the past, people could go out, people could be visited by others, people would commune. When you're alone, it's easier to take your life and without anyone, I mean, interfering. So there are lots of factors that we don't know. Still, we don't know, and we will learn maybe in the coming months or years. I mean, is there something called post-COVID depression? I'm not sure about this. I mean, the closest example I can observe is my older brother. Um, he's 7 years older than me. He said, I mean, he had COVID 2 months ago, and he didn't have to be hospitalized, but he had it. I mean, he was, well, not so severe, but a moderate case. He said, I was in tears when I was watching a TV soap opera. This happened for the first time, he said. I mean, he felt depressed without any apparent reason. We don't know if we will be encountering organic, organically caused depression or any anxiety disorder in the future. So, I mean, the future is I mean, there are so many unknown things about the future of COVID.
I want to, if it's okay, I'd like to go back in time a little bit. We touched on this just briefly in passing earlier on the 1999 earthquake in Turkey was absolutely devastating. And it was, I don't know, the figures in the earthquake deaths can often be quite misleading because there's the quake itself, the collapse of buildings, but it was followed by a fire and also a tsunami. I mean, it was just a catastrophe. And I know that you spent, as you said earlier on, 2 years studying that. And I wonder if you could talk a little bit about your own work there. I'm interested in what you learned there, and then how you've been able to apply that to thinking about this disaster. And I think it seems like there's, looking at the mental health, of victims and families is one part of it, but you also developed an interest in first line responders and health professionals themselves and their own mental health and disaster, which 1999, that was pretty cutting edge stuff. I think it's a little bit more well studied now, but you were really doing some path-breaking work then. Can you talk a little bit about that?
Yeah, I mean, I thank you for, I mean, letting me talk about '99 earthquake, because I think it changed my life for good. I was at the same institution that I'm working now in Hacettepe when the earthquake happened, but I was not I was not happy. I was having problems with the department head, and I was. I mean, it just happened at a time, at the right time. Well, this is ironic. I'm saying right time, but for me, for my life at least. And after the earthquake, the a colleague of mine who was working at London University, he said, well, I'm starting a project backed by London University. Would you like to come and work with me on that? And this would be something I like, and then quit my job at Hacettepe and move to the area. I mean, I lived at the fault line, actually. I mean, just 50 meters away from that for 2 years. And I was supervising psychologists who saw patients who, I mean, not patients, but I mean, earthquake survivors, who treated them. And I also conducted research, which also became my PhD thesis for London University. So, I mean, I learned a lot, and first how to assess in detail people who have endured such a horrible, frightening event. And also, it was the first time that I developed an interest in positive outcome of such events. And I think, I mean, if we have time to talk about that as well, I mean, it's the research we proposed to the Converge, the consortium, the project that is headed by Laura Peak, who was also your guest 7 months ago. And I think, I mean, it's much common for people, for researchers, to look at the negative outcome of disasters or adverse events, which is quite natural, because in the medical school we learn about all the adversities. I mean, what's your symptom? I mean, yeah, do you have pain? Do you have nausea or something? I mean, we don't ask you how happy you are. We ask you how sad you are, right? So, I mean, it was the first time I realized that we could look at this, and the mayor of the town, it's a small town called Değirmendere, where I lived. It was just at the fault line. And when I was talking to him about my studies, he said, "You know, it's interesting that you say this." He said, "I didn't know such a thing existed, but I'm very happy that I learned about this positive outcome, the positive possible outcome of this." Because he said, after the earthquake, as a mayor, I feel more useful. I mean, this is such a time that, I mean, I haven't felt so good before. I mean, everything I do is useful. I mean, it saves some people. Everything I do is meaningful. And before that, in the normal, so-called normal times, I mean, we were just passing, killing time. So now I take a decision. I demolish a building. Everything I do touches someone or helps someone. And so we saw many other cases. I mean, I remember, I mean, the widowers of dockyard workers, and the an uneducated woman, a housewife, suddenly became a worker at the I mean, shipyard, because her husband died at the earthquake, and they had to what I mean, employ their wives to keep up working. And these women, so I've interviewed some of them. They are so different. They said, "Well, I feel so different and so confident than before. They have taken up the role, their job of their dead husbands, but they have the breadwinner. They become the breadwinners of the families. They feel more confident. They were the well, they were the leader in the house. Now they become the leader outside as well.
Right.
So this phenomenon. I mean, and then I contacted people from North Carolina. I mean, there are well-known researchers, Tedeschi and Calhoun. At Charlotte, and I actually met them and visited them afterwards. So I try to include in my assessment in any study at least some part of some questions on positive outcome. So it's not. I think this is not just devising a complete and comprehensive assessment. I think it's also useful. I mean, to give the complete picture. I mean, I think also it's politically correct as well. Let me just finish but
Yeah.
one sentence. I think. I mean, when I talk to the doctors around me, my colleagues, everyone is talking about how this pandemic has hit us, how I mean, how it is killing us and suppressing us and so on. I think we also need to show how strong we are. I mean, we as doctors are trained to fight adversities like this. Okay, I mean, yeah, I mean, when I jokingly said that there will be an alien invasion and sometime in the future, we will be the ones to fight this. So we are trained to resist this. So I think we need to include the assessment of positive outcome as well.
I thank you for that discussion, and it points to so many things that I've been struggling to conceptualize, and it's really helping me think through. We have a hard, even the way you started that, to talk about that it was a moment in your career in which you were ready for a new set of challenges. And we have a hard time talking about solidarity in disaster. I think partially just because the frame and the media-driven frame often is one in which you're looking for greater and greater levels of devastation. And there's even a term for this now that I've heard in the last few years, which is disaster pornography. That it almost becomes that the most outrageous scenes that can be shown are the ones that are going to get clicks, they're going to get views. And I'm not faulting the full news media, because I think there's a lot of great disaster journalism out there, including great photographers and filmmakers, but that effect is clear. And so what you're introducing here is a needed corrective to that, which is that there can be great value in studying from a social science perspective, I think, particularly a mental health perspective, the reinforcements, the solidarity, and you described the positive things that come from that. Finding purpose, finding a reordering of the social order. These things happen a lot in disaster, but we almost always measure those as dysfunction. Finding function is what seems to me you're describing. So I wonder if we could go a step further with that, and if you could say a little bit more about how you might apply some of those things you learned in '99 to the kinds of questions that you're asking today about, what the situation in Turkey.
Right. I mean, I think. Well, I haven't heard about this disaster pornography, the term, but yeah, I think it tells a lot, and it's also, I mean, you can also see it in I mean, scapegoating in times of a disaster. I mean, I think I've seen in the U.S. media as well as in Turkish media, people going to the beaches, for example, and it's a crowded beach. Is a good picture to appear on a newspaper, and for people to get angry at. I mean, those selfish people. They go to the beaches. They crowd the beaches and so on, which is, I think, one of the least likely places to acquire COVID. I mean, it's the indoor places. I think, yeah, this disaster pornography is common everywhere. The I mean, what I learned in '99 is, in addition to assessing psychopathology or negative mental states, I learned to focus on positive sides as well. And I think I will. I mean, we have not yet started the study that we proposed to the Converge study group, which was to study around 500 healthcare workers all over. I mean, from several different institutions in around Turkey, and I was our team and I were planning to assess them on the effects of mental health effects of COVID, but as well as the resilience factor. I mean, I think if we ask them questions on how they manage to continue keep going, and what the factors are for their, I mean, strength, and if they have come up with something positive. I mean, it's most of the time, people, when you don't ask them such questions, they don't spontaneously come out. I mean, it's not easy for someone who has endured so many adversities to say, well, I grew in that area. I'm much better in that area. So I think even just asking those questions can raise awareness. And if you manage to disseminate this information, say, I mean, we assessed 500 doctors, and they have endured so many things. They have seen people die in front of their eyes. They have seen colleagues dying, and but still, some of them have I mean, most of them have survived this. They continue fighting, and plus some of them have even say they're much better than before. I mean, we get the vaccine, and we're much better than before, right? I mean, before the vaccine, we were more susceptible, weaker, but after the vaccine, we're stronger. It's similar when something. Well, it's a very well-known saying. It's the thing that doesn't kill you makes you stronger.
Mm-hmm.
If you are in a fight, you are. What I mean, it's the stealing effect. I mean, you're just you fight, and if you win, you're much stronger. I think if we just make people aware that there is this possibility, it will be. I'm planning also to disseminate it through the media as well. So I think the people would be. This will help their mental health in a positive way in the end, although indirectly. Let me just add one more sentence. I think I need to do this. Assess the positive outcome in the general population as well, and also in COVID patients. I mean, we will be starting soon an assessment of COVID. Patients who had COVID in our hospital. We will probably reach around 600 cases as well. And I'll ask people if they have endured positive change, or people who have lost loved ones to COVID, if they had any positive change. Because I mean, if you're not accustomed to asking such questions, it may look odd, but people who have lost someone can grow in some ways, and they may become more mature, more loving, more giving people after. I mean, compared to before their loss.
I can only imagine that even having to contemplate that question in a moment of stress is also can provide help and for a form of coping.
Definitely.
Just a quick reminder to everyone you're listening to COVID Calls. I'm talking to Dr. Cengiz Kilic today about the pandemic in Turkey, and we're talking about the 1999 earthquake and implications for today. We're almost up on time, but I did want to get to a couple other things quickly if we could. One is maybe you can help me understand. There's been a lot of reporting last year, particularly, about some of the issues around reporting cases in Turkey. That's not unique to Turkey. We've seen similar questions raised in China and the United States as well, where the reporting was variable in different states as well. Talk to me a little bit about that. What did you notice in that regard? How has the case reporting changed over time, if it has?
Yeah, I think that's an important point. I starting in March, the Minister of Health, actually the health minister, took charge, and he appeared on TV every day, and started reporting systematically. And in the first weeks, I mean, he gained lots of popularity. Although, I mean, Turkey is a politically very divided country, polarized country. I mean, I could observe that most people believed and had trust in him, but I mean, slowly after some weeks, when the numbers, the death toll increased, and the number of cases increased, they I mean, something suddenly changed, and they started reporting. I think it was in May. I think no, in July. In July, they started this switch to reporting number of patients instead of number of cases. And when the reporters asked, well, why this was the case, they said, well, I mean, it's a more realistic picture, because I mean, case I mean, could be symptom free. I mean, someone who is symptom free is a case, but the patient has symptoms, so it's more clinically meaningful. So, and they well, I think many people believed. They didn't like the figures. They would them to look nice and low, but they couldn't keep this up for long. After 2 or 3 months, I think sometime in the autumn, maybe it could be September or October, they switched back to cases. I mean, because of the political polarization or the division in the country, many people still believe that they're not telling the truth because of the fluctuation in the number of tests done each day. I mean, when you look at the numbers, on some days you see 150,000 tests. The next day you'll see 90,000, which doesn't make much sense. And plus, the mayor of Istanbul, who is from the opposition, he started declaring the numbers of deaths each day in Istanbul from any cause, which he proved that it's much higher than last year, which could also be a sign of numbers of COVID being reported low. So I think my reliable sources, the medical Association of Turkey and other Psychiatric Association of Turkey, and when I listen to those people, I can see that the government does not report the numbers of COVID, test negative COVID patients, which we know there are a lot. I mean, there are people who are dying of COVID and they're still negative.
Right.
So, I mean, if you are positive, it means you have the virus. But if you are negative, it could be either way. I mean, so the test has a very high false negative rate. That's the thing. I mean, I think I'm almost sure that they're downplaying the numbers. But the best educated guess would be, I think the real numbers are around twice that reported, but not 10 times or 20 times, but probably, I mean, 2 times would be more realistic.
And that situation you described so resonant with what we experienced in the United States, which, and the part I'm particularly impressed by you pointing out there, that once trust is breached,
Yeah.
then it's very hard to repair as the disaster unfolds. And so you might find people who have a great amount of faith in science communicators, in health officials, or whatever. But when there's a rupture there, it's hard to rebuild that in the moment. It sounds like that's what you're describing there. I just want to get to one more thing before we wrap up. I know you mentioned you're considering doing some mask research there. With such a complicated topic, a fascinating one, an important one. What are some of your thoughts about that? People who won't mask in Turkey. You mentioned maybe some claustrophobia concerns. I mean, these are health concerns, mental health concerns, or is it more a political statement? In the United States, it's also complicated, but quite often it's a political statement more than anything else.
Yeah, I remember Trump removing it, right? Before he gave the speech, one of his last ones.
Yeah. That was his patent. It was his patent moment, I guess, taking off the great defiant leader.
Right. I think I suspect that the political statement part is much less in Turkey, but I mean I don't know for sure. You said at the beginning, and one of my main interests are the anxiety disorders and phobias, and I was always planning. I have been planning to conduct a study on simple or specific phobias like claustrophobia, animal phobias, and things like that. About a month ago or 2 months ago. One of our residents approached me saying that she wanted to do a study on claustrophobia because her husband is the radiologist working in MRI scans, and there are people who can't go in MRIs, they're claustrophobic. And I said, why don't we do a study on study of claustrophobia in mask, about the relationship with mask wearing? I think I said it's a big issue. She said, "Why not?" And now we applied to IRB, and we're waiting for the response. And we'll go in the field in a couple of weeks after we receive that. All assessment is ready, and in the studies when you look at the literature, there are several factors that affect your wearing a mask. And I mean, some of them are physical. Some people don't like it. They give them, I mean, rashes, itches, and so on. They say they cannot breathe. They say, well, they cannot run and do their work. And so on. And some say, well, no one can dictate me. Things like that, all right? And the political statement one. And some are the conspiracists, and they say, well, there's no COVID. I mean, they're fooling us. I don't need to wear a mask, and they say that so many people died. It's a lie. Have you seen anyone dying? I mean, that's another group, and some say, well, I mean, they make this. They make it a law to wear a mask because they want to sell masks to everyone, things like that. So I think claustrophobia will come out as a strong predictor. I just don't know. I mean, what's the percentage? I don't know if it will come out as the first and the strongest, but I think it will come out as one of the strong predictors of mask wearing, because I see so many people wearing the mask but leaving the nose out. Mm-hmm. So we know that. I mean, there are scientific studies. We know that wearing it over your nose doesn't lower the oxygen levels in your blood. So I mean, it's just feeling more comfortable with your nose out, which I think will closely relate to claustrophobia. And if we can show this, we'll have a strong position to suggest that, well, we need to treat all claustrophobics to reduce the cost of I mean, COVID, so we will save some lives. That's
Mhm.
that's the main thing underneath that.
You have so many lines of research going. I want to remind everybody you've been listening to COVID calls, and you can catch COVID calls usually at 5 p.m. Eastern time. Today, special time, 5 p.m. Korea time. And just a reminder, on Monday at 5 p.m. Eastern time, I'll continue my discussions as part of my partnership with the LePage Center. And my guests will be Jessica Martucci and Britt Dahlberg, and we'll be talking about their project, Experiences of Recovery, Disability, and Politics in Pandemic. So please do join me for that, 5 o'clock on Monday. And I want to thank my guest, Cengiz Kilic, for this tour of your research you have ongoing. It's extraordinary, and I wish you the best of luck with it. And with the Converge study, it's going to be a heavy lift, but I really am excited to keep up with it and hear about the results when they start to come in. Thanks for your time today.
I thank you, Scott, and for giving me this opportunity to talk at least about some of my research. And I'm very glad to have met you. Thank you.
Same here. Stay healthy, everybody. We'll see you on Monday, 5 o'clock.